Top Med Talk.
Hello and welcome to Top Med Talk Down Under. I'm Kate Leslie and I'm here with my co-host Andy Cumpstey at the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine annual scientific meeting. And we're in the top end of Australia at Cairns in Queensland. It's a beautiful location. We're having a fantastic time, Andy.
We absolutely are. And again, it's a fantastic ASM annual scientific meeting here in Cairns. And we've just come from another brilliant session, the Gilbert Brown Prize session, with lots of really, really impressive speakers.
Yes, there were a combination of things actually. There were surveys, observational studies, quality improvement projects and randomised trials. And it's great to see those emerging investigators in their suits and looking, very intense about presenting their research in front of the judges.
And you're a former winner of that prize, are you not, Kate?
I am, but that was a long time ago, Andy, which you love to point out.
I did not point that at all. But I was going to say, can you remind our international listeners about what the criteria are or what gets people into that session?
It's for research that's been done within, I think it's 8 years of becoming a specialist anaesthetist. So trainee anaesthetists and consultant anaesthetists can apply. And that's the only criterion. And they get 10 minutes to present and 5 minutes of questions. In the past, all the questions were proposed in person, but now it's all through the app. So it's a bit more civilised.
It's quite an intimidating place to present with the bell going on time, and all the speakers did very, very, very well to present to the second.
They did.
Full marks from me. That was impressive.
So we'll look forward to tomorrow when the winner is announced.
Absolutely.
So now we are very privileged to have two fantastic guests, Alana Flexman and Maryanne Balkin. Alana, welcome to Australia.
Thank you. It's lovely to be here. Very different than my hometown of Vancouver. Lots of rain, but very humid and warm, which I love.
Have you been to Australia before?
I have once before, but a long time ago, 20 years ago. So it's nice to be back.
Excellent. And what's your day job?
So my day job is I'm an anesthesiologist, but also a researcher. So I split my time. I do about 3 days a week clinical and 2 days doing a variety of academic roles and research, which I love. So I feel like it's taken a while, but I've honed my career into a path that I really enjoy that gives me both sides of clinical and academic work.
It's great to get that balance.
Yes.
Yeah. And Maryanne, can you tell us a bit about yourself?
Yes, I work as a full-time specialist at the Alfred Hospital in Melbourne. Like Alana, I have non-clinical roles and clinical roles. I do 3 days a week of clinical work, and that's fairly mixed, but with a focus on airway cases and ENT. And a lot of my non-clinical time is taken up with tasks that are related to my role as the airway lead in the hospital, and there's a lot of education and policy and equipment stuff and just trying to keep up to date to make sure that we're providing the best sort of patient-centred care that we can.
And you went back to school and did a Juris Doctor in law and also a Master's. Can you tell us what inspired you to do that?
I guess I really can't answer that question without admitting there was a level of craziness to that decision, I guess. And I've never really come up with an excellent answer of why I did that. But I was always really interested in the intersection between medicine and law, and I find that doctors in general don't have much understanding about law, although we do interact with it quite a bit in our role. And equally, when you hear lawyers talk about medicine, you often sort of realise, as knowledgeable and as accomplished as they are, they really, and why would they understand our clinical role? So it was quite enticing to me to have the ability to sort of have some understanding of both. Of course, my career is still as an anaesthetist, but I am really enjoying pursuing some sort of academic interests in that sort of crossover between both.
And we'll get to some of the interesting work that you've done when we talk about women in anaesthesia and in research and clinical practice later in the podcast. But we're so lucky to have Alana here, who's forging a great career as a woman and a researcher in Canada and increasingly internationally. How did you get started on that journey, Alana?
Oh, well, Kate, it's been a bit of I'd say a good dose of craziness in my career as well. Can relate. I guess I feel like I've had a little bit of an unconventional journey in academics per se. I did do a fellowship. I did my training in Canada and then a fellowship in the US for 2 years, which was really amazing, and was introduced to some great mentors, Adrian Gelb and Pekka Talke, and they actually really taught me about academics and research in a way I hadn't been taught before. And so I was always intrigued to do an academic career, but it was difficult when I got back to do that. So I kept going back to it, basically. I don't know why. I can't explain it fully, but I really love research. So I kept doing it on my own. And eventually it mostly was focused on neuroanesthesia, which was my clinical specialty. But I really I was able fairly freely to pursue whatever topics I wanted because I wasn't really bound by a lot of, university requirements and whatnot. I was doing it on my own time. And that was great. It was very interesting. I really loved it. I got to mentor students and we got to go travel and go to conferences, and it was very, very satisfying as a career. And then at some point I got interested in equity work and gender equity. And I think you get to a point in your career where you realize there's a time that things need to start changing and you want to be part of that change. And because I, at that point, had done research for a while, research was my skill set. And so I decided to apply that into gender equity research, which was great. I have a great collaborator in Toronto, Gianni Lorello, him and I have actually done most of our research together. And I think that was really critical to have the two of us both have complementary skill sets to be able to do that.
Yeah, it's a great journey. I mean, it's good for our listeners to know that you don't have to do your training program, then do a PhD, and then do a postdoc, and then concentrate on the left part of the heart or the right part of the heart, or this particular thing for the rest of your career. I remember Professor Jamie Slay saying that his career had been a fascinating wander through interesting stuff. You know,
exactly.
So it's great.
Yeah,
I was going to say we're fortunate, Kate, to speak to a lot of guest speakers through Top Med Talk. It's amazing how often that phrase comes up, that I had an unconventional career or I took a different route through. Or we hear that time and time again. But I wanted to come back to you. You mentioned it was difficult to get into research, even though that was your passion. Or what sort of difficulties were you experiencing? Because I'm sure there'll be some of our listeners at home that will resonate with all of those same experiences.
Yeah, absolutely. I mean, I think the challenges are common in many universities. It's about funding, and the university getting positions became very, very difficult in that time in terms of becoming a full faculty. And we're very fortunate in anesthesia that we are generally well paid. So you can sort of do it yourself in a way and still, obviously we're fine. So I was able to do it on my own time, but it was a bit of a, because I didn't have clear structure around what I was doing, and it's difficult to sometimes find mentors in anesthesia, and so I actually went outside of anesthesia quite a bit. So I worked very closely with a group of spine surgeons who were really excellent. We did a lot of work in frailty and spine surgery. And then I also had collaborators in stroke, in neurology, and outside the university and other centers. So I have a very big network of people I collaborate with and I find that very satisfying, not only to get your research done, but they're also great friends now, a lot of them. Like, it's a nice community. So I think that's one of the benefits of academics is actually the community and that you're contributing something back in a bigger way. And then I was thinking about craziness too. I went back and did an MBA 4 years ago, which was also crazy. I don't know why I did it in some ways, but I thought about doing more research degrees, but I actually decided to do the MBA because it was different and it was a new skill set that was business, and I was going to be able to talk to people in administration in a different way that had more credibility, and also support some of the equity work because it's a bit of an advocacy thing.
Maryanne, you must have noticed having a law degree has helped you talk to people in power in various spheres.
I think it's had as its advantages and its disadvantages, I guess, because if you're talking about change, you're talking about disrupting the status quo, and that is sometimes difficult. I really identify with what Alana said about just changing the way you think a bit, because I think it has changed the way I think and approach problems. But it's certainly not the be-all and end-all, because we often can see what needs to happen, but that sort of gap between what's happening now and what needs to happen sometimes is a difficult journey.
I'm going to come back to that phrase you both used about the craziness of doing something different.
Mm-hmm.
How do you put yourself forward to do that? I mean, you both got busy day jobs as anaesthetists, and then I'm guessing the law degree was outside in your own time as well.
It was on my own time.
Yeah, so I mean that's a huge commitment you both make around family and friends. And
Yes.
how do you make that commitment and do it? How do you make it work?
You have to be very organized. You have to enjoy what you're doing. At that point in your life, you're not doing it because you have to. You're doing it because you want to, which is a different way to do school. I'm sure I love school. I know that's nerdy. I'm sure you do too if you did another.
I can't explain it.
Yeah.
And I'd say the only other way through it is with a lot of apologies.
Yes, agreed.
There was a lot of times where there were so many balls in the air, and I would just have to say, I'm sorry, I forgot. I'm sorry, I wasn't available. I'm sorry. And fortunately, my family, for the most part, has been understanding. I'm not saying completely lacking in resentment, but generally supportive. So yeah, that's it's been a cost, but like Alana, I identify with almost that addiction to learning and just having new skills.
Yeah, I think that there's a lot of women in the higher, in leadership in medicine who share those qualities of being productive and organised.
Yeah.
But also being addicted to learning and to finding out new ways to do things. Because I think as women, the old ways that we've been doing things haven't worked, or some of them haven't worked, and there's more that we need to do. So maybe we should turn to that now. What activities have you been up to recently, Alana, in this women and gender equity space?
Yeah, so I have a few things I've been doing. So my research program, I still continue to do original research around equity issues, and that's been very, very satisfying and good. And I think it's a big part of the filling in the puzzle of actually identifying, quantifying, and showing the world where these gaps in equity are. It's the language of medicine, so I feel like people listen when they read an article, even though it's sad, but sometimes they need to have it in a study before people believe sometimes what's happening. And so I think that's a really important step, and there's a lot of people doing really important research in this area as well. And it's been really nice to see that it really grow in the last, I'd say, 8 years. And then alongside that, I've taken on a number of roles around equity in research or academics. So one of them is I have a role in my university department to oversee the equity portfolio, which is really great that our department is quite trailblazing in Canada to even have this position, which is great. And so what we've done is we have a curriculum for our residents to go through around equity. We've reviewed a lot of policies and procedures in the department and tried to modify them to make them more equitable. I sit on the executive committee, so I'm able to contribute to general discussions and whatnot. And I think it sends a strong message that it's important to the department, which I really appreciate.
Same question to yourself, Maryanne.
Yeah, I guess it's really interesting, the sort of changes in the narrative around gender equity since, I started as a consultant back in 2008. And I feel like the narrative when I started was very much, the women are lucky to be here. And, that eventually that wasn't enough for a lot of us. And so I feel like we're earlier in our journey than it sounds like in Alana's department. But in my department, we sort of started a gender equity committee in about 2018, I think, and shortly thereafter I joined the gender equity subcommittee at ANZCA. And that's been, really incredible in sort of providing me with other people to talk about and to learn from. And I was really lucky to be a part of the ANZCA gender survey that was done in 2022, and to just meet these amazing other fellows who are on a similar journey, and just trying to sort of bridge that gap between, being the change and trying to make sure that the people starting as, trainees and consultants now are, not facing quite the same structural inequity that we might have faced.
Do you think that's working?
I think it's really slow, but I think if I, consider where we started from, and even to raise it as an issue was seen as whinging and hysterical, to now sort of saying, no, everybody's realising that it's, it is an issue, and it's an issue that collectively we need to address. And in addition to that, there's so many other areas with intersectional identities and things that can really multiply disadvantage in the workplace. And I think we're really early in engaging with that, but at least we are now aware and we're trying to do something about it.
What are you going to talk about in your talk this afternoon, Maryanne?
I'm going to talk about the lawful management of bullying, discrimination and harassment in the workplace. That was the subject of one of my essays for my master's assessment, and we were lucky we could choose our topics, and this is something that I really wanted to understand better, because I sort of saw in the different places I've worked over my career very disparate approaches to this in the workplace, and I wanted to understand, at least as a bare minimum, what are the legal obligations that we need to be fulfilling in this space. Because although, very few people will go to the effort and, put themselves in the position of making a formal complaint, that doesn't change the fact that everybody has responsibilities and needs to be accountable for what goes on.
Mm. And is there a similar law in Canada about bullying and discrimination in the workplace?
I don't know the law in Australia, but I'm sure it's quite similar in terms of protections that are in place. In Canada, we face perhaps have some unique aspects in that physicians, trainees are employed by the hospital system, but all of the consultants, once you're into practice, you are a self-employed contractor, and you actually don't have you don't have an employer. And that actually creates problems in this arena, because there's not a clear structure of how you approach the workplace. So fascinating topic, and a lot of legal aspects to that as well. Yeah.
That's particularly interesting, because a lot of the law reform that's gone on in Australia is actually tightening the rules around what the employers need to do. And if you don't have an employer, it would be very difficult, I imagine, to address that.
And there's quite a few different parties to it. So we have, our college regulates our university and our hospitals, and they're all different, and it's complex. I think there's been a lot of work and progress in the area, in my area, around these issues around discrimination, harassment, particularly of trainees, in the last 5 years.
I think, firstly, it's massively impressive and well done for all the work you've both been doing in this space. The theme for this meeting has been future-proof all the way through, and we've had that as a theme running through our podcasts with all the different speakers. It was the theme in the plenaries. How do we future-proof this issue, because it's not going to go away?
No, I think that we need to move into a bit more, Alana sounds like those sort of policies and agreements of sort of the terms of the operations of departments are really important. And certainly what I'll be talking about this afternoon is the change in the lens from the individuals. It was sort of, we've had a huge burden on victims of this sort of behaviour. You know, you need to report, you need to do this, you need to do that. And that is sometimes just unfathomably difficult for them. So what the Australian law is trying to do in this space is to change that emphasis from what individuals need to do to what the employer and the managers and the workplace leaders need to do. And the first step in that is really challenging a lot of the assumptions and the sort of unconscious bias that all of us have. And the first sort of step in that is admitting that you have it, and then trying to work out how is that affecting my role or, you know, the decisions I make at work. So I think there's a lot that needs to be done in terms of education, number one, and also having workplace leaders undertaking unconscious bias training and really engaging with this sort of work.
I think while they're doing that, they could do conscious bias training as well.
They certainly can.
I mean, I feel that myself.
Yes.
I think having done a lot of this type of work, it's brought it into consciousness. And it's sort of disturbing when you recognise your own biases. Have you done much reflection on the way you operate in the world, Alana?
Absolutely. I think that's part of the journey as well. And even as part of, I remember a talk I did a long time ago, I took the unconscious bias test I think Harvard puts out that you can do online. You can just see. And to make a point almost, I have unconscious bias against women in science when I did the test. And it just shows that that's the least of it. I have other biases too. Like, you have to recognize them and then actively work against them. So
you have a bias towards or against women? Against.
This is a test. Like, you try to not have it, but it's a very fast association test.
Yes, I've done the test.
Yeah. And
Yeah.
I have 3 sisters who are engineers. Like, I shouldn't be biased against women in science, but that's how it came out, interestingly.
There's an intersection, I think, also between, there's intersectionality in lots of ways, but there's intersectionality with respect to age.
Oh, yes. Yeah.
And I think it's different for women and men.
Mm-hmm.
So I think the esteem with which men are held and their authority might increase with age. And I haven't experienced this myself, but I perceive a bias in myself towards women, older women, I think.
Yep.
Sometimes it's a very strong societal stereotype.
Yeah.
I think it's ingrained. I think it covers every aspect. Like, you see what happens even with Hollywood, and, the men just keep getting the roles and getting the roles, and women over the age of about 40. It's, and I feel like it's pervasive across work, across, like you say, society.
Yeah. Agree.
I wonder in the last few minutes if we could just pivot slightly, and again, picking up on what you just talked about, but Alana, you gave us a fantastic plenary session probably a couple of days ago now about a changing culture and changing specialty. Mm-hmm. And I think it's worth acknowledging that as well in this space, as well as in what we do. But I wonder if you could just summarise some of the issues you picked up in that for our listeners at home.
Sure. Yeah. This sort of centered around, it sort of brought in my MBA training around value-based care, which is something I hadn't really conceptualized of, but this idea of how do we actually provide the right value, the right outcomes for the patient, and also considering the costs of that care that we give to be the most optimal. And I think our aging surgical population is a huge challenge for us going forward. And I've seen it even in my 20-year career. I can absolutely see a difference in the types of patients that we're looking after now. And the more I've practiced and encountered these situations, I think that using, having some formal approach to it and tools with it, that was one of the take-home messages, was that if shared decision-making with our patients is actually difficult to do, even though it sounds easy, and that we can really benefit from taking more time and having more resources towards that to make sure we're doing the right thing going forward.
I think all of us around the table here can relate to the fact that we're anaesthetising older and older patients, and again, that's not going to change either. But you gave some really nice examples in the plenary of case studies and differences in emergency and elective and outcomes, and I wonder if you could just delve into that a little bit deeper for us.
Sure,
as well.
and these were the cases I presented were actual cases I had just in the last few months of my practice. It wasn't hard to find them, and they're just cases where it happens quickly. There hasn't been a lot of time for actual discussion with the patient, who might be very elderly and have a lot of medical issues. And now you're committing them to a procedure like a pacemaker or like something that may not be super invasive, but it still has its risks and complications and implications for going forward. And so I think those examples really highlight the challenges that all of us face every day. And we're not actually, at least in Canada, we often don't have the time to spend to do the right thing. And that's one of the struggles I see. And but yet I think there's easy things that we can do to make that better.
Such as
we have referring them to another specialist, like a geriatric specialist that has the time to do that, to spend a long time doing a thorough assessment. We have palliative care. We have a palliative care physician in our department now who's very useful in terms of discussing these issues, who has expertise that many of us don't have. So I think using those resources is very useful, and then delaying to actually have that conversation versus just going ahead with surgery is a good thing.
And Maryanne, does that relate to your practice in Australia? I mean, we definitely have those services in the UK.
Yes. So at the Alfred, in the last, I think it's 18 months, we've recently introduced a peri-op service, and at the moment that involves the meeting of the team in the morning, and it includes a geriatrician, a physician, an anaesthetist, and as well as the junior medical staff. And we review the patients on the round each day, and a lot of the decision making is about the suitability of patients to go to theatre, what needs to be optimised, and sometimes that difficult decision to make of, we're not going to proceed with active management here. And it's a new service, but it's getting a lot of very positive feedback, and I'm really glad we had to self-nominate about being involved in it, and I'm learning an awful lot from the geriatricians and the physicians.
And it's a great new career avenue for women and men in anaesthesia who want to mix it up and do something different, do some new study and keep learning. So thanks so much for being on our podcast, Alana and Maryanne. It's been really fun.
Thanks for having us.
Thanks for having me.
Yeah, and you can hear this podcast almost everywhere, Andy. You can hear it through the Answer newsletter. You can find it on our app and on our website, and there will be links to it on our social media pages. That includes Facebook, X. We're now on Blue Sky as of Saturday, and we're also on YouTube. So please follow us on all of those sites and repost and like things as much as you can if you do actually like them. Do you think they like them, Andy?
Well, people are liking them on Blue Sky, so I'm hoping that means they do. Well, I guess go on and have a look and then let us know.
Absolutely. So finally, we'd like to thank our sponsors, BD, GE and Solventum, without whom we could not bring Top Med Talk free and open access to the world. Thanks so much.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.